The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to another episode of the Success in Practice podcast. Look, normally I introduce the guest and we start off that way. But today I'm going to kind of take a different direction and I guess maybe have a little chat about some current events before we introduce the guest. Nothing too long, I won't bore everybody, but there's always things happening within, I guess, not just osteopathy, but the allied health space that might be interesting. One of the things that I do want to say is that normally you've been seeing me on these, if you've been watching and not just listening, you'd see that mainly I wear the Make Osteopathy Great Again t-shirt, and I've been promoting that. But today I want to say a shout out to Lisa DeStefano over at Michigan State University for this lovely t-shirt that she sent me, Neuromusculoskeletal Medicine at Michigan State University. I know the visceral people are going to probably hate me for this with the neuromusculoskeletal medicine, so sorry for all those people. Someone's always going to get their knickers in a knot, but that's okay. So special shout out to Lisa for sending this t-shirt. It's great. I've been wearing it out promoting osteopathy. So now if anyone wants to get some of the Make Osteopathy Great Again t-shirts, there's a link in the show notes where you can click on that and just go and order your men's or women's Make Osteopathy Great Again original tee. So if you've enjoyed me wearing those, I'm not the best model in the world. I gave that line of work up a little while ago. But if you like that t-shirt and you want it for your clinic, just click on that link and go buy that. So one thing that's happened, I've heard about this week, and as this episode goes to air, it'll probably be about 2 or 3 weeks out, but we will be getting close to that July 1st deadline. It looks like that the government has increased the award wage for I guess osteopaths or allied health professionals who are on the employee model. I think the base wage now is $93,000, and that's a pretty significant increase. It's probably it looks like it's about a 10 or 15% increase. And so what that's done to that employment model is still a little bit unknown. It sounds like that it's definitely going to really hit those bonus structures really hard. So it sounds like that people who are currently employing osteopaths and offer them bonuses for reaching certain targets are now going to just expect those targets to be reached and not really award a bonus, because the bonus is going to be in the award. And so it'll be interesting to see how that plays out, especially in Melbourne, where there's a lot more clinics, I think, who are operating under that model. And I know a few people down there are going to be a little bit anxious about what the future holds. What it's looking like is that it's going to be very, very hard for new clinic owners who want to go onto that employee model to compete. You know, it's expecting new graduates to come out on $93,000 a year. The clinic would have to be bringing in at least $200,000 a year, $200,000+ a year to make that work of revenue. And so I don't know of any new graduate that is doing that. I don't know that the universities are producing graduates that are capable of producing $250,000 worth of revenue in their first year out of university. I'm not saying it can't be done. I haven't seen it in the last probably good 5 to 7 years. But I guess good luck to people who are taking on employees. It's going to be a tough gig there. And if you are a new graduate, I guess your role is to just upskill yourself as much as possible, so that you can be competent and confident enough to to treat your patients and get a great result out of them. And I guess that's a couple of the things I'll probably discuss with my guest tonight, is about the quality of graduates that we're seeing, and also what they can do, the graduates themselves, to actually improve their skill set and to earn some extra money. And anyway, without any further interruption from me, I will introduce our guest for this episode. We've been trying to put this together for a little while. So today I'm quite glad that I'm joined by Syed Hussain. Syed studied osteopathy at RMIT, and in 2013, after watching a video of Brian Tuckey treating tremors of a patient, he started to look for counterstrain training. And Brian is the founder of Functional Counterstrain. So that was a life-changing moment, and functional counterstrain training has become part of a lifelong journey for Syed in terms of his continuous education. Syed undertook the first course in functional counterstrain. Fascial. Thank you for correcting me, Syed. Fascial counterstrain. The word functional just comes to my mind for some reason, but it shouldn't be. I should purge that. But yes, fascial counterstrain. To do with the lymphatics and the venous system. And he did that with Timothy Hodges, and has since studied the full curriculum of fascial counterstrain courses with Brian and Tim. Syed is very passionate about fascial counterstrain and has begun sharing the technique with fellow Australian osteopaths, so they too can bring this powerful technique into their clinics and be part of changing the lives of their patients. In 2022, under the direct supervision of Tim Hodges, who's one of the founders of the Counterstrain Academy, Counterstrain Academy Melbourne had officially started to operate and run academy courses. So he's now working at Complete Health Osteopathy in Gladstone Park, Victoria. Syed, mate, thanks for being on the podcast, and welcome.
Glad to be here, Sammy. Thank you for inviting me. Sorry
for that error, mate. I often see a lot of this functional nonsense on my news feed, and for somehow functional just got implanted in my mind. I guess that's how it all works, and that's how shit travels down, I guess. But sorry about that. It's fascial counterstrain.
We're just getting used to it ourselves too.
Yeah. Well, I mean, we're used to just calling it counterstrain, so I will go on and ask you about the differences between the two. Yep. And I assume there would be some differences. But before I do that, people are interested in your backstory. Syed, tell us about where you're from, where you grew up, yep. A bit about your childhood, and maybe your early life before osteopathy, and then what led you to osteopathy.
Well, typical growing overseas in Pakistan, in a small kind of town. Father wants me to become an engineer. So I always found structural kind of structures very important to look at. Used to look at the bridges and stuff, and they kind of like excited me. So decided to become an engineer, and did my physics and mathematics major in both of them, and then decided to come to Australia. So came to Australia when I was 19 years old. I've got no idea why I actually decided that. So I was actually quite fine, but decided to come here. It's just like had no idea where I was going. It was towards the other end of the world. Anyhow, came over here, studied my computer science at the time.
It's usually for the beaches.
Yeah, well, I actually, believe it or not, I actually had no idea what was different between Perth and Melbourne. Because I still remember my first day in Melbourne, and my brother goes to me, because my brother he's been living in Japan for a while, for about 50 plus years. And he goes to me, he goes, why don't you contact my friend, he's there. I'm like, okay, I'll call him up and I'll see what he's doing, and call him up. I goes, hey, how's going, everything? And he goes, oh, welcome to Australia. I'm like, oh, thank you. He goes, where are you? I'm like, I'm in Melbourne, you just want to catch up for coffee or something. Let's go for a coffee or something, just catch up and we'll have a cup of coffee, maybe a dinner or something. He goes, oh, I'm in Perth. And me having no idea about geography, my geography is still bad. And I said, oh, okay, so would that take about 45 minutes, roughly? So, yeah, now that was my introduction to Australia. I had no idea.
Well,
Studied.
one of the things is that it looks like, I mean, just watching it looks like there's snow outside your windows, mate. And that's one of the differences, I guess, between Melbourne and Perth, right?
Yep,
Is the
I
weather.
actually learned, yeah, I learned it the hard way, hard and cold way. So, studied here. I studied again computer science because some of my friends were studying it. So I thought it would be a cool idea to just go with them to the university. Did that, start working as a programmer. Got bored the hell out of it because it was just you're sitting in a cubicle and working as a programmer. Not much entertainment in that sense. Because I'm a martial artist, so I'm a bit more hands-on kind of activity. Into the health, I was always mystified by the Chinese medicine and the little bit of the Japanese masters who I used to train with, and they will do some kind of weird stuff, which now we know that is the acupressure or the acupoints that they use to treat people. So that was my kind of like introduction to the health system, and that was the end of it. Became a teacher later on because I thought that would be a better idea than just working as a programmer. And then taught for a while. While I was teaching, I had a work accident where, while playing soccer, twisted my knee and busted my ACL. And so went to the surgeon. He said that it's busted. You have to do the surgery. No issues. I trusted the surgeon with my heart because, as you do. I'm not in the field. He's in the field. So I will trust him. He said, you need to do the surgery. So we did the surgery. I did the rehab to the best of my ability. I could do very long jumps and whatnot after doing the rehab, but there was still pain.
What year was that, Syed?
So that would have been about 2010.
Were they using hamstrings then, or did they use your quadricep?
Hamstrings. They're still using
Right.
the hamstring. So
Yep.
they use the hamstring graft. And I had no idea at the time because my anatomy knowledge at that time was zero. So whatever they said, I just shook my head, did my rehab, still had pain. My surgery was in 2008. I did the surgery, then I went to have a little bit of other jobs in teaching, but it was still painful, and I couldn't concentrate. On me being the engineer mind, it was always like, why there is pain? I've done everything they told me to do, and I'll always ask the surgeon the same question. I've done everything you told me to do. Why I'm still in pain? He goes, it is expected. Maybe it's all in your head. I said, it's not in my head. I know that.
It's in my knee.
It's in my knee. It's hurting.
Yeah.
Every time I do something, it's hurting. One of the person sent me to this Chinese medicine guy in Richmond, and I actually can't remember his name. I think Dr. Richard, his name was, and he actually treated me. The pain disappeared within one session. For 50% of the pain disappeared, and I was like, that's actually quite amazing because I've been taking tablets and I've been doing everything else, and nothing was working, but this worked. So I said, okay. I asked the guy, I said, how do you learn what you are doing? Because I want to actually get into this field. So, cut the long story short, I went into RMIT, applied for TCM, got into TCM, and tried to start to make sense of a little bit of what Chinese medicine was. Used to see these people across the side, on the other side of the hallway, these weird-looking people sitting outside on the floor. And, me being in Chinese medicine, you have to be proper. You have to be walking with the straight posture. And these were the osteopaths sitting across. And I had no idea. Somebody said they're osteopaths. I'm like, osteopaths? Bone pathology? What does that mean? So I had no idea by that time. I had a lower back spasm during that time, which I went to see a lot of the students' clinic, like TCM guy, even the one I was seeing, Dr. Richards, he couldn't fix it. I saw my teachers at RMIT in TCM, they couldn't fix it. And one of the other student that I knew, he goes to me, why don't you go see Dr. Ray, because he's running a study at the moment for lower back pain. So I said, okay, no problem. By that time, I was already in second year of my Chinese medicine. I said, yeah, I would actually love to do that. Now, there was a little bit of story before that. While I was doing second year, John Marshall, I think you know John Marshall.
Yes.
So John Marshall came as a tutor at the time, and he was tutoring us on the med exam. From my questions, he looked at me, he goes, why are you doing TCM?
Yeah.
I'm like, because that fixed my knee a little bit, so, it was good. He goes, with the way you are talking about anatomy, you should be an osteopath. And I'm like, okay. So that was in the back of my mind, that would be an osteopath. And then we went to the study. Ray Myers got me on the table, and he
Lucky you weren't asking John about like a wife or something, mate. So what are you doing with her?
Go over there.
You should go with that one.
So I still blame him for him putting me into osteopathy.
Yeah, right.
So that was John. You know how casual.
Yeah,
he's
John's
casual,
very casual, and the way he speaks, it comes from the heart. So you really believe him.
Yeah. It's
oh, what are you doing with that girl? You should be with that girl. Yeah.
and the thing is, because he's John is also martial artist, so we connected. So because he's done Aikido. He's doing Aikido. I've done Aikido. I've done other karate and all the rest. So it was very, very it just kind of like connection there. So I'm like, yep, okay, I'll keep it in the back of my mind. Ray Myers, this is what exactly happened to me. I'm in that, on the examination table. He goes, lower back pain. I'm like, yes. No, it's a randomized trial, so he's not going to tell me what he's doing. So he comes and he held my ankle. So I went like that. I'm like, I said, Dr. Ray, the pain is in the back. And he goes, it's okay, lie down. And I'm looking at him. He goes, lie down, I'll give your legs back to you. It's okay. And he did a little bit, so just a little bit on the ankle, a little bit on the knees, a little bit on the pelvis. Mind you, by that time, I already have seen osteopathic students and some of the osteopathic practitioners, but the lower back spasm didn't go anywhere. Ray, on the other hand, that was literally about, I think, 5 to 7 minutes, if that. And he goes, all right, that's it. So in my mind, I'm thinking, damn, I was in the control group, in the placebo group. So I just got done. And I'm like sitting there and like, that was bad. Like, I should have gone the other way. Yeah. And I'm asking the other person, are we going to get treatment from him? And they go, we can't tell you anything. Okay. Came back home, and I'm like, I don't have any pain in my back. What happened? So next day I went up to Ray and I said, what did you do? He goes, I just did some functional techniques with the biodynamics. Now the biodynamics, my thinking was biodynamic. Is he talking about some V protein or something? I had no idea what biodynamics was at the time. So what's functional techniques? And all he did was 5 minutes. So that piqued my interest. And I said to him, Ray, I want to actually learn what you do, but I want to do what you do, not what everybody else is learning. So can I start doing osteopathy? He goes, you are already doing Chinese medicine, so for you to be able to do that, you have to actually give up on that and do this. I said, yeah, I don't mind. And then he gave me about these many books. He goes, go read these. So these were the old osteopathic books. And when I read them as crazy I am, I just started reading them, went through the entire books, went back, and he actually tested me. I wasn't I wasn't sure why I was doing that. And he goes, all right, when the admissions open up, I'll let you know. And then he got me, as soon as the admissions open up, he goes to me, congratulations, you got the osteopathy, but if you want to continue with your Chinese medicine, you can. So I was doing all of them at the same time. So I was doing the Chinese medicine and osteopathy, and I think it was 4 degrees at the same time. So I was learning all of them. As I kept doing that, so that's a background, and so went into the course of osteopathy, had been very lucky because we had very good teachers at the time. Sharon Burke, we had Paula Henderson, Heather Monroe, Ray Myers himself, and Kylie. So as a clinician, we had very good team. They were excellent. Chelsea was there too. So it was a very good team. They were working in a synchronization, just everything osteopathy. So I would go there, like I would say the only other person I saw early in the time, that I'd go there to the university at 8 o'clock and I'll leave at 9:30 when the library finishes. And Ray Myers' car was still standing there because he would leave even after me. So as I started doing osteopathy, I will go and I'll ask question from Paula, I'll ask question from Ray, Heather, and they were very generous. All of them, I would say, with their time, as many questions I had, they were answering it. And then Ray, because he used to run the extra classes where he would teach you. So normally it ended up being 2 or 3 students. So it used to be 3 or 4 students who will always be there. And I went through all of that with him, did my osteopathy studies. What I did do though, what Ray suggested, he goes, when I was in because I did first and second year combined for the osteopathy, he goes to me, in second year, once you are finishing this year, go and look at all the other osteopaths, how they are trading, and how the, the other people who are teaching it. So I started learning from the, going to the courses, towards the end of my second year, like first and second year combined. So first year in osteopathy, I was actually going into the courses. So I went into, at that time, there used to be the Sutherland Academy. They called somebody from overseas. So I'll go as a gopher over there. Then they had George, who used to run the courses. He still runs the courses. So I went to his courses, like Baral courses. So I went into the Baral courses. So I did everything because I wanted to see like what was the depth of it and what osteopathy really is, because everybody says that we are doing the right one. And I wanted to see what is actually osteopathy, what it is. And I will always make it linked back to the practicality. So being a martial artist, I mean, this is my major thing, I think, in this field of osteopathy, that when you're doing a martial arts, if it is not pressure tested, you could be thinking that it's going to work every time. But if it's not pressure tested, if you haven't applied it and you haven't tested,
been in a fight,
you don't know if it's going to work, right? If there is no, so there has to be an objectiveness to your style. Same thing, I applied it to the osteopathy. So I was like, okay, I can say that I feel great, that the tissues are relaxing underneath my hand, and I can do this. But how do I know? Because Ray asked me once, he goes, how do you know if you have made a change? And I'm like, range of motion? He goes, and I said, they will say that pain. He goes, what if the patient is too polite and they say that my pain has lessened quite a bit, just to make you feel happy?
Yes.
I said, oh, does that happen? He goes, here, yes, as a student clinic. When you go outside, you won't see them again.
Yeah.
It doesn't happen. So he said to me, he goes, that's what you got to actually put your focus on. That how do you know when you have done something? How do you know? There has to be a measurable, something reproducible, measurable outcome of it that you should be able to see. Like if I'm doing, let's say, straight leg raise, if it is 45 degrees, it should be 90 degrees. If I think what it is, it should be 90 degrees after that. If it is not, it is still 45 degrees, and the patient is saying he's feeling great, well, might be just trying to please you, which is not a good thing. So he actually mentored me quite a bit on that aspect. So this is where I started going more into practicality aspect of it. So, the osteopathic career, we go more into where you go into the technique part of it, then you go into the philosophy part of it, and then you start making sense of both of them together. And then first you say, these old osteopaths, they've got no idea what they're doing. Then later on you say, oh, okay, that's what they were saying. And then it's back and forth. That's what I was going through at that time. So a period of, how would I say, evolution of osteopathy for myself. By the time I graduated, I already knew that I need to actually open my own practice.
Right.
During the RMIT years as a student, I was actually working 3 days or three days in RMIT, whereas the students are only were working at 1 day, because in the clinic you were having 1 day. So I actually ended up having 3 days because my schedule was getting full while I was a student at RMIT. Now, my thinking was that I have to see if it is because people are getting free treatment, or is it because I'm getting good at my skills? So my question always used to be the same. How do I measure?
So is that why you opened up on your own upon graduation?
Well, my thinking was that what I started doing while I was still at uni, I started going out and challenging myself in front of my friends and the others. Can I fix them?
Right.
And then I would do it under pressure, because that's how you pressure test. Like, if I can stay calm and my limbs are still relaxed, that means I've got something going on. And like, in terms of that, I'm developing my skills. If I get sweaty, which was in the earlier days, all the time, you get sweaty. You're like, I'm not sure what I'm doing here, whether was I able to diagnose this? Am I correct in what I think it is? And by the time I finished, I knew I wasn't gonna be good fit in any of the clinic, until that clinic goes with the same philosophy that somebody is coming with the back pain. Am I able to get their back pain from treating their foot or treating their neck, or can I assess them completely? And
So sorry, let me. So why were you placing that kind of pressure? I mean, are you saying that you wanted to be able to, for example, improve back pain just by adjusting the foot?
no,
You wanted to have that kind of impact.
So what I wanted to have was, back pain can come from the foot, like
It can.
from the biomechanics, right? So that was just an example. So I wanted to see, like, if I go to a clinic, do I have to do it the way that they will teach me, or can I do it independently, whether I assess the entire person?
Well, wouldn't they just be interested in the outcome? I mean, if you're working at a clinic and you're getting good results, if you're getting results and patients keep coming back to see you, I mean, at the end of the day, the patient is the market. If they continue to come and see you, then the principal of that practice should be quite pleased.
Yes.
If they don't see you and you don't grow your patient list, then they will probably have a chat to you and they'll say what's going on. So, I mean, why would that? Yeah. So why would somebody, I guess, interrupt that process? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
I think in the beginning, because my fear was that I will not be able to get the results that I wanted in the beginning. Right.
Okay.
So for me, it would have been if I'm faced with that dilemma where I have to please the principal osteopath, because obviously the clinics are not running on thin air. You have to actually
No. But they're there to help you as well. I mean, you are a new graduate. It's not like they're expecting you to cure cancer on the first day that you work.
Exactly.
Right.
Second day maybe.
Yeah. But so yeah, I mean, they're there obviously to mentor you and help you get to a certain level. Did you understand that as a graduate?
At that time when I graduated, I didn't have much information about it. So my thinking, what we got, because one of the guy who graduated earlier than us, that's what they said, that you have to go and you have to get the customers, you have to bring them in, and you have to do what they tell you, you have to do the massage, you have to do this. And I was like, I don't want to do all that, because I want to concentrate on the results, because my understanding was you get the results, word of mouth spreads, then you get the patients coming in, the flow will be unstoppable. If you get your skills up to the level where you are good enough to get the results, get the relief to the patient, if the patient will go and fight on your behalf and market on your behalf, because that's how I saw from the older books of osteopathy, that's how it was.
Right. And
that's how I saw Ray Myers and the others when they were trading. They got the same results. So people will go and say, oh, this guy did this, A, B, C. And this guy have done, like I was in pain for, let's say, 5 years, and now my pain is gone. So you have to go and see this guy.
Okay.
So that was, which, I mean, to be honest, because there wasn't many marketing at the time when I was graduating.
I think I was around the same time that you were around, so I understand that in those days, word of mouth was extremely powerful.
Extremely powerful, yeah.
It's still extremely powerful, but you have other things now that you can kind of fall back on.
Social media.
Yeah. so I understand that. In saying that, though, I mean, in hindsight, looking back on it now, do you think it would be a good idea for you to maybe find a clinic that's a bit more aligned with your values and maybe spend a year or two there?
Yeah, you know, I would have learned heaps if I actually started with that. Because for me to start my own practice, I made a lot of mistakes because I had no idea what I was like.
Yeah, I mean, you learn from those.
Yeah.
Yeah.
Hard way.
Yeah.
But it would have been a great idea. And this will be my advice for the upcoming graduates that go and find the clinic, because I didn't know it back then what I know now. A lot of the osteopaths will welcome you to come and observe. Go and observe. Learn from which clinic aligns with your values. What you want to do, or what your goal is in life, in osteopathy, in your career. That's what you want to be aligned with. And you will learn a lot of skills that you will not learn anywhere else. And then you will have to do everything from the beginning, which I had to do. I had to learn a lot of that. And I had to learn the hard way. Thanks to Jade, I was actually attending one of her seminar when she went to Victoria University, and I had a good chat with her. And you know how she is. She let out everything. You have to do this, and she explained everything. And that actually made me quite well aware of a lot of the things. And I was like, I should have actually gone and learned a little bit more before I started doing all that. But now, yes, going back, if I had time to go back, I would have gone to a clinic which was more in line with what I would have been doing, and then take it from there. So,
Yeah.
yep,
Yeah, all
that's
right.
definitely.
So, okay, so you graduated, you opened your own practice,
Yep.
and then, I mean, tell us about that. So that you just grew that organically?
Yeah, so what I did was 2013, as I mentioned on the web, like on my page as well. I saw Brian taking. So actually, I had another episode of back pain, and Paula Henderson gave us an assignment to do on counterstrain. So that was my topic, and I'm like, okay, let's see what counterstrain is. So I had a little bit of back pain, and as I'm doing the assignment, as you do, you start poking for the tender points.
Yes.
So I did poke one of the tender point. I was like, oh, that really hurts. I had a bunk bed and put my legs kind of like a T intersection or whatnot in the position of ease. The tender point went, and I went to sleep. Woke up 3 hours later, and I had no pain in the back. So I was like, ah. And I went very excited, told Paula. Paula said, yeah, go on and observe more and learn more from what you have explored. I'm like, okay. And I tried to find everything counterstrain after that. So I did classic counterstrain. I went to Japan to learn from Ed Gehring. This is all during my time at RMIT. Then I came across, as I'm doing all this, then I saw one of the video with Brian who treats intentional tremors. And the person is actually literally shaking, and then his hands are solid. And it's like, And call it a calling. I send him an email, and Brian Taki, the humble person he is, he actually replies back. And he goes, thank you, this, and these are the courses I'm running. And he's like, I've learned from Dr. Jones, and this is my new stuff that I'm coming up with. He explained what fascial counterstrain was. And I got interested, so I chased him after, went to France, did my courses over there. Like, first course was here, did the foundation, did the lymphatics, and the results kept improving in my student clinic. So then I was able to translate into my practice. So a lot of the people, you know how you tell your friends. So the good thing was that I tested myself under pressure with my friends and whoever I could find. So I would go to the mosque, and there was somebody who was in pain, and I'll say, oh, okay, let me treat you. Let's see what I can do. And then I'll try it. And if they get better, and this is how the word starts spreading.
Yeah.
So,
yeah, definitely.
And I'll go to the market, like organic market, and I'll treat the person on the fruit crates. And then get him to do, okay, how's the neck now? Beautiful. And that's how the word starts spreading. So, and then when I opened up my own practice, it was like kind of like very easy transition to it because people already knew. And what I did was I deliberately went into a medical practice. The reason was because I wanted to see, because at the time I didn't know what to do. What they put me to do was, I think it's illegal now, 15 minutes to 20 minutes appointment. So I had to diagnose, treat, and do my notes in 20 minutes. I became very fast at it.
Yeah.
And that was like, it was a really good learning curve at the time.
Yeah.
So
That's pressure, right? You talked about pressure earlier.
Pressure testing, yeah, again. So it came down to that. So I learned NKT, neurokinetics, where the touch and inhibition was there. And then because FCS or the fascial counterstrain, Brian put all of that together. So everything, what he did was he made the diagnosis, the basics of FCS, where you are quite specific to what you're going to treat. So you can find the key lesions, so to say, area of greatest restriction, and you can use touch inhibition, you can use cranial scan, all of them put together. It will give you one area to treat, and the results are amazing. That's fascial counterstrain in a nutshell.
Yeah.
So, which I'll talk more about what's the classics and the fascial counterstrain, the difference between the two. So I'm pretty sure everyone who's in osteopathy would know about Dr. Jones, how he came across the...
They should.
They should.
But
We're hoping they should.
we'll get you to speak about that because some may not, but they should.
Yeah. So Dr. Jones was, I would say, the third generation of osteopaths because he learned with William Sutherland. So from William Sutherland as well. So he was kind of 1930s, 1920s graduate. He came across somebody who had psoriasis, or the one of the condition where the person couldn't stand up straight, and then he, after he manipulated him because he thought that he was better than the chiropractors, so he thought that he could manipulate him to health. Couldn't. The guy said, if you can just get me to just maybe sleep better, maybe that will help me a little bit. So he probed some pillows and put him in a position which made him a comfortable position. Comfortable. So the guy went to sleep, and Dr. Jones went and treated another patient in his other room, came back after 30 minutes, took the pillows out, the guy stood up straight, no pain. And that was the start of Dr. Jones. Like somebody like us, we would say, oh, yeah, good, great, see you later. Yeah. Dr. Jones started, yeah, that's it, done. And Dr. Jones actually went to explore more, and up until 1998, he was exploring how to treat these tender points and what tender points he was finding out. He permitted 4 different people to teach. He only allowed 4 people to give license to 4 people. Ed Gehring was one, Randall Kusanose is second, Herman Myers was third, and Brian Tuckey was the 4th. Now, out of the 4 of them, I've trained with 3. So I've trained with Ed Gehring, Randall Kusanose, and Brian Tuckey. Herman Myers, he passed away before I started osteopathy, so I couldn't get to him. So that was one missing. But the classic counterstrain approach was that find a suitable position which will take away the pain of the tender point, and which will decrease the tender point sensitivity from, if it was 10, you will decrease it to 70%. Or that's what we are taught at universities.
And from what I understand, there were specific movements. It wasn't just always about a position of ease.
Yes.
And I think that's what a lot of people mistake it, is that,
Yes.
oh, you're just looking for a position of ease.
Yeah.
It's not just some of those tender points are counterintuitive to the position of ease.
Exactly.
And so it's best that people go and explore that and learn that for themselves.
Yeah, because for example, AC7 or the PC7 tender point, which is at the back. So rather than extension and moving towards it, you're doing an extension and moving away from it.
Yeah.
Which is what now we have changed it to the brachial plexus technique, where you actually go into the brachial plexus in FCS and you glide the specific posterior part of the brachial plexus to decrease the inflammation. Using that.
Yeah, even the OA tender points, you think that they go into extension, but it's actually flexion.
It's flexion, yeah.
Yeah.
And now we know that they are a little bit different because some of them are epidural plexus and some of them are the arterial, and that's the difference between classic and FCS on a very minute level. That classic was because Dr. Jones, he said that these are neuromuscular tender points. He never said that these are muscular tender points. So he was always on the same point that it is not a muscular technique, it's not roll and fold, which is normally thought to be the case. FCS, what Brian has come up with, his engineer, is a cranial scan. That's one of the proprietary for Brian. Where you can have the entire scan of a particular system. So you can have anterior longitudinal ligament, you can have posterior longitudinal ligament, you can have the viscera, which goes around the mastoid process, and this will tell you the anterior visceral points and the posterior visceral points pertaining to some of the visceral structures. Now, include that with the motion testing. So in the classic counterstrain, what we used to do, you have about 200 tender points. So you will start from the neck and you will go all the way down. And you will palpate all the tender points. And you'll do the tender points at the back. And you will decide whichever tender points you want to treat during that treatment. And as Dr. Jones said, that treat the tender points that are more tender than the other, even if it is distal to the point of point of complaint. So that was his part at the time. Now, sometimes it would be great the way we used to treat. Sometimes it will hit and miss because we weren't sure what which tender points we are looking for, which one we miss.
Yeah.
Whereas FCS is different on that aspect, that we are actually now more categorized. So if it's a visceral tender point, I will go so I'll use touch inhibition with the scan. I will find the scan. So let's say if I have median umbilical ligaments, which is one of the visceral tender point, and I'll find the tender point, the location, then I'll go and I'll check with my scan. Does this scan takes away the tender point? And does this tender point, because works both ways. So if I go to the tender point, does that makes my scan get better as well? Once that happens, does also, if I inhibit this scan, does this make my motion testing better? So now we have the functional testing, we have the motion testing, we have the tender points, we have the touch inhibition, and we have the cranial scan. And then we do another thing we have added, which is taken and refined now from Ed Styles' greater area of restriction, and that has been included into FCS. So now we actually find the key lesions as well. So you could have a lower back pain, which once we go through all this process, and we'll say that this is the tender point, which is causing that restriction, could be very distal, which, to start with, to Dr. Jones' credit, that's what he used to say. Even if it is distal, find that tender point. And then once you treat it, it actually gets better. So there's a huge difference in terms of systemization of the tender points. So now we have tender points with every single system. We have arterial, lymphatic, superficial fascia, we have the muscular fascia, we have the ligamentous, we have the ligaments, we have the viscera, we're gone into the periosteum, into the brain, and we are treating the brain structures now as well, using those tender points. So FCS has become what I used to read in the older books, as doctors still said, that if somebody comes with the wrist pain, you look at the lymphatics, you look at the arterial, you look at all these anatomy, and then you look at the physiology of it, and then you go all the way and look for where you find the restriction. And if you look at Little John, he would say, look at the restrictions in the body, and that restriction can be anywhere that will cause a pathology in the long run somewhere else in the body. So then these two put together, and I would say Brian has kind of like revived that osteopathy bit, because it's easier for the graduates to get in.
With regards to the fascial counterstrain, the points, the scanning, and what you just described, how does it tie into, say, other technique applications? Like, how is it affected, for example, with a cervicothoracic adjustment? If I was to find a restriction into a joint, and I found some, I guess, correlating points, some tender points. Would I be able to kind of address some of those through other means rather than just using fascial counterstrain?
Of course, because what you do is, let's say it is, so we have the diagnostics, right? The part which was missing from my understanding was that we were kind of like lost in the diagnosis, because diagnosis is the key. Once you have the established diagnosis, even if you're spending 20 minutes into it and just the 5 minutes treatment, if your diagnosis is correct, that 5 minutes treatment should be enough, right? So cranial scan is actually a diagnostic process. So now what it does, it puts me into a system, right? So let's say you have a CD junction restriction. Now I can go and I can check. So let's say if I know quite a few scans, and I can go and I say, okay, I have done, let's say, one course which is only the ligamentous, right? So I can go and I can see there is this restriction in this area, which is kind of like a ligament that is giving me a ligament at CT junction. And it's ALL, or anterior longitudinal ligament. So now anterior longitudinal ligament, if I'm going indirect, I'll go and I'll shorten the structures. If I'm going indirect, if I'm going direct, like indirect would be going this way. If I'm going indirect, then I'm going into the extension. And then I'm going to go, let's say, whichever way, the side bend or rotation, and whichever way, and then I'll apply my manipulation. So what cranial scan has done, it will put you specifically at a structure as well.
Okay.
Because it can be as specific. So if I was to do my own scan at the moment, and I can just go very quickly, and I have just behind my coronal suture, I've got this restriction. If I was to show it, it's on the camera, it doesn't really move. Where if I go a little bit further, that moves. And if I go here, that doesn't move. That means at the level of, on the left side, I've got a dysfunction that correlates to this scan.
Yeah.
Now I can actually go, if I'm flexible enough, I can reach up here and I can touch and inhibit. So I can see if this is a tender point that I need to inhibit. And then when I go at the same area, that actually starts to move. And that puts me into the area. Now, from here, I can take it and I say, okay, this gives me ERS or FRS. Is it extended, flex, rotated right, or is it flex, rotated right? Whichever way it is.
So would I then apply the technique, and then could I recheck that scan and see if that's had an effect on it?
Yes,
Right.
because then you will be able to tell, yes, I have improved it, and that scan has now become negative. So I can't do the HVLA on myself, but if I was to do it, then we can show it. But
And so is this, a lot of this underpinned still by the concept of facilitation? Is this still a facilitation kind of concept?
So
is there another concept behind what's happening here? Because the scans and the tender points and I guess the release of those have to be connected somehow.
yes.
Right? And you mentioned neuromuscular earlier.
That was from Dr. Jones.
That's right. And so is this still underpinned by the concept of facilitation?
So 2022, Brian has published a paper because he went into in partnership with some of the Jay Shah and some of the other researchers who are in the pain management research, and some of the people from the lymphatics kind of researchers as well. And he put them together. And what we know now is that's his paper. He's publishing another paper, which will be the rationale for us now, that it is what happens is when you are putting these indirectly, so we are talking about the counterstrain or any of the indirect technique, when you're putting them into this facilitated positional release.
Positional release, yeah.
Positional release, what it does is release the lymphangiones or the lymphatic or the inflammation, which is stopping the lymphangiones or the pumps inside the interstitium. So what it does is that we have inflammation whenever we have an injury, insult, or whatever pathology. There will be inflammatory markers or the cytokines that are sent by the body to stop those area from moving. Hence we get these restrictions. Once we get these restrictions, and then that's where it becomes chronic pain because the signals are going to the brain telling us that there is still...
but this is still neuromodulated, right? Like you're describing a paper, or you're telling us about the paper that tells us what they think is happening physiologically.
Yes.
But the modulation for that is still a neurological kind of
the basics
phenomena.
of it is still, we're still talking about the nociceptive reflex, right? So
Right.
we're still talking about the same, that you get the signals that goes into the brain, and then the brain sends more inflammation down there, and then the cycle keeps on going, and then you end up having the chronic
Yeah,
inflammation.
I guess the greater point that I want to make to the listeners is that whether it's traditional counterstrain or whether it's
Well, the method doesn't change.
fascial counterstrain, it's not just the method that doesn't change. I think
Yep.
the fact that you can integrate this into a greater osteopathic treatment still applies.
Yes. Yep.
It's not a standalone. It's not a standalone kind of concept. It's still, you still need to apply osteopathic rationale, and you still can couple it with other treatment techniques. It's not something that just, it can stand on its own, but it's something that also can be coupled with
Yes.
other treatment modalities. Would that be a fair enough statement?
So when you're starting, obviously, you can start with the mixing the two methods together, obviously.
I'm not talking
because-
about, no, I wasn't really referring to mixing the two methods just on their own, but I'm more talking about within the osteopathic treatment. I mean,
Yep.
you know, it's not like you just do fascial counterstrain. You know, you could
Right.
you could obviously do some fascial counterstrain, or you could use muscle energy technique. You could use HVLA. You could use functional technique. You could use something, and that may still correlate with an improvement in the scan. Would that be correct?
It will. So this is where I think there's a little bit of whether we have done the testing with all the osteopathic techniques that will change the scan.
Right.
We haven't, because obviously we only did with the counterstrain. So I can only tell you that with the counterstrain, yes, we can make the scan negative. With the HVLA, would it completely negate the scan? Because the rationale is at the moment that's what I was trying to get at. That rationale is that we are removing those cytokines. That hence the time period that it takes for it to release all those cytokines from the interstitium. Whereas if we are doing HVLA, does it take away all of the inflammation from the area? So we haven't done that.
It wouldn't. It probably wouldn't. Based on the rationale for HVLA, it
Yep.
wouldn't do it immediately.
Exactly. So it will take some time, whether if the joints are back into the position as HVLA would have aligned them back into the.
Well, if the
remove-
HVLA technique has brought a positional balance to the segment,
Yeah.
which is probably a better way to frame it. If you've bought, whether you're using HVLA or MET or a stretch or an articulation,
Yep.
if you've brought a positional balance to the segment that you're trying to affect,
Yep.
how quickly does that then affect the inflammatory response, the cytokine response that you're referring to?
Yeah,
I would say that wouldn't affect it immediately,
Yep.
and would be part of the greater treatment that you would be applying.
Yeah.
And that would require the body to then pick up the mantle and regulate and recover, and then you would obviously see some changes, hopefully within 24 to 48 hours.
Yep. Whereas with the counterstrain, that's something different, because when we put it into the positional release, it actually does release the entire inflammation, because we have done that over and over again. Hence, the results are reproducible. Hence, we can say with confidence that it has been done again and again. So there are some videos, as Brian has done with some of the treatments, where people actually went through the surgery, and then we went through the same techniques, similar kind of presentation, exactly the same results.
Right.
So-
And what are you finding in terms of range of motion testing? Is that correlating positively with your findings through the scan as well? Like, I mean, I'm coming to see you with neck pain,
Yep.
and I need my neck moving better.
Yep.
You produce you apply some fascial counterstrain.
Yes.
The inflammation, from what you're telling me, the inflammation improves,
Yep.
but yet I want my neck and my pain to reduce
Re-
and my range
reduce.
of motion to improve.
Yes. So
And so that's the outcome I'm focused on as a patient.
Yeah.
Yeah.
And that's what, remember when in the beginning I was talking about that, how I was very much oriented on how do we measure it, right? So this is why I fell in love with this, because I can actually have that range of motion, and then I will first, before even I start the treatment. So this is the power of it. So I will actually inhibit my cranial scan. I think because Gus has gone through a little bit of what the fascial counterstrain was a little bit. My assumption is. So
Little
I
bit.
will, yeah. So I will actually inhibit that cranial scan, and then I'll see if that improves range of motion or not. Because touch and inhibition, because it's a temporary kind of like feedback into the system, which will inhibit, and it should improve range of motion if we are on the right structure. So if the cranial scan moves it, then I will go and check the tender point, whether it is still moving it or not. And with the tender point, the range of motion should still improve.
Okay.
That's where the touch inhibition becomes really important.
Okay.
So then once we have done that, and then we treat the tender point, the range of motion, as soon as I finish treating the tender point, range of motion will improve.
Yep. Yeah.
So
okay. Interesting.
So it is like where you have, for example, let's say if you came in with the neck pain and we are checking your range of motion in terms of extension, flexion, side rotation, and side bending, and you are stuck in, let's say, one or three of the motions. If I find the right scan after diagnosing, going through the motion testing, going through my touch inhibition, going through my cranial scan, and if I find the right system and I do that, then by theory, it should improve all these three range of motions because I'm on the right structure. If I haven't been able to do that, that means that I'm not on the right structure. Now, having said that, could it be multiple structures of the body that can cause the restriction of the motion? Yes. So then what I need to do is to inhibit, rather than one scan, I'll actually inhibit two scans and see if these two, what I'm thinking, am I correct or am I not correct? So it gives you the answer before actually you start the
So it's a
treatment.
process of elimination, really.
Process of elimination, and it actually puts you in there within 2-3 minutes very quickly.
Yeah. Okay.
So it's
Right.
quick and it's fast.
Okay. I want to move on and speak to you because I think you're now. We mentioned in the introduction that that I think it's the Counterstrain Academy in Melbourne has officially
Yep.
started. Is that correct?
Yes, it has.
And you use that particular academy to teach fascial counterstrain. Is that
Yep.
correct?
Yes.
So how's that going for you? How has it been taken up by the profession? What's been the uptake like? How's that happening?
Uptakes by the people who have come and taken the courses. They were very happy and really amazed because at the end of the day, it actually it is what excites us as osteopaths to be able to see the results and actually help the patients. That's what makes us osteopaths in terms of the broader concept. When they come to do the course, because everybody comes with obviously predisposed, they've done something in the past, or
Yeah.
a lot of the people, they come with it direct. So I had some of the chiropractors coming in and learning it. I have some of the massage therapists, myotherapists coming and learning it. And I had osteopaths coming in learning as well. Younger people, or I would say the osteopaths who graduated within 5 to 10 years time, and recent graduates, they pick it up very quickly. And they are actually happy to come and do the courses, and then they really get hooked on. Whereas a lot of the older osteopaths, and I'm saying it only based on few of the osteopaths that I've, and having said that, obviously there are other osteopaths who are older and they love it. I mean, Roger Kingston is one of the example. He is the avid, he's one of the best, I would say, advertisement for the
Right.
FC, because he is always like, you got to do this. So he's
Shout out to Roger.
always, so he is actually one of the major kind of guy who's telling everybody, you got to do this because it is good. And this is somebody who's done osteopathy for about 40 plus years. Having said that, I have actually met some people, and I would say just online, because what they said was, this is not osteopathy. They haven't done the course. They may have watched one of the webinar with Brian in terms of what he was explaining, a little bit of what FCS is, and they said this is not osteopathy. It's just a technique. It has no philosophy in it.
Right.
And they actually say that, and it's like, have you done any of the course? Have you actually met the guy? Have you talked to him? And they go, no, but it is this what it is. And from my understanding, it's like, I understand why you have reservation about it, because
But does it have its own philosophy, or does it share osteopathy's philosophy? Like,
well,
does it have its own set of principles, or does it share osteopathic principles?
it is osteopathic principles. It's actually, there's no difference whatsoever. It is based on osteopathic principle. Brian always starts with the osteopathic sayings and put it together that this is what the osteopaths were doing. This is what it is.
Right.
This is putting it together.
So when you teach it to chiropractors and myotherapists,
Yep.
do you find it difficult? Do they find it difficult? And in your experience, has that been a problem where they find it hard to wrap their head around the underpinning principles behind what you're trying to teach them?
I would say yes and no, depending on individuals.
Okay.
So if the chiropractor, I mean, obviously you can't fit in the treatment for 2 minutes. Just joking, like you can't do this treatment in 2 minutes. So they will have problem if they are trying to fit in
Right.
that. But having said that, there are chiropractors who actually love to apply the osteopathic principles. They would learn, they go out of their way and they do the osteopathic courses and they learn from these guys. Like as you're wearing the shirt from Michigan State University. Now, Brian is a graduate of Michigan State University. He did all the courses over there in the older days. He didn't do, so he is trained as a physio. However, I haven't seen any other osteopaths who can explain the osteopathic principle the same way as he does. Because if you look at his lineage, he's trained with Ed Style, he's trained with Greenman, Philip Greenman, because he used to be there.
Yep.
And he has trained with Dr. Jones directly. He's his protege. So if you count all of that, and then he learned with Randall Kusanose, who has trained with Kimberly, who has trained with Dickey and all the big osteopathic names from Kirksville. So my understanding is that if they have learned from the osteopaths, they have learned the philosophy as well, because from US they actually did the exact same thing, and that's what Brian does. I don't see, having learned both. I've done FCS is my main method of treatment. I don't see a difference at all.
A difference between the traditional and the...
So the traditional osteopathy and fascial counterstrains.
Well, it's not that there would be a difference. I don't disagree with you that the underpinning of counterstrain, let's talk about counterstrain, just put fascial counterstrain aside, it was born out of osteopathic principles. It's a technique. Exactly. And the way that osteopaths, for example, would apply HVLA is different than the way that a chiropractor would apply HVLA. The reason behind why we apply it is different. Now, in saying that, I've taught many chiropractors, and they ask me, why do you apply HVLA? And I tell them, and they're like, oh, okay, that makes sense. And so that might then become their reason. So it's not that a chiropractor or a physiotherapist or a myotherapist can't learn principles. They can, just like we can. But at the end of the day, the principles are still osteopathy, and the technique is fascial counterstrain.
Yep.
It doesn't stand on its own 2 feet without osteopathic principles.
Because it is osteopathic in its entirety. That's what it is. And the thing is, like, this is where I've had this discussion. Somebody actually sent me a message saying, why you guys are teaching it to massage therapists and why you're teaching it to the chiropractors. It should stay within the osteopathic community. And I said, I disagree. Because this is where, and I'll tell you what Ray Meyer said in 2016, that osteopathic profession will split into 2. He said the way we are going, osteopathic profession will split into 2. The reason for that is because osteopaths will lose osteopathy and they will become exactly what the other profession did and join in the normal mainstream kind of medical, leaving their own diagnosis and own philosophy behind. And you see that very often now. I mean, before when we graduated, it was very different to how the graduates are coming up now. I mean, I did a presentation in RMIT the other day, and I went through the entire history of osteopathy. And most of them actually weren't taught that. And for me, that was a bit of a shock. I was like, didn't you know these guys? And we were talking about, Greenman. We were talking about Mitchell Senior, Fred Mitchell Jr. We were talking about these are the names everybody knows. Like for you and me, this is just a common thing. And they were actually not taught about that. So it's like, what's going on? And why do you apply a technique? We use our philosophy. Chiropractors will apply a technique. Hence, that's a chiropractic profession. That's where the osteopaths, when they filed the case against the chiropractors, it didn't go anywhere, because when the osteopaths were asked question, can chiropractors do what you guys do? And they said, no, we can't do they can't do what we are doing as osteopaths.
Yeah.
So that was the main reason. The philosophy was there.
Yeah.
And now if we are not following that, how can we call ourselves osteopaths? If we are not making any innovations in the field. I mean, you look at the earlier part of osteopathy, there was a lot of innovations. And you look at now, it has just gone down the very different path. We are trying to amalgamate into our physiotherapy. So,
Yeah, no, I agree with you. I think looking at, I guess, different techniques and new techniques and expanding existing techniques is is something we should be doing. But I think we need to also differentiate between the technique and the rationale.
Yes.
Right. And so if we understand the rationale, we can use any. I mean, I had George Stillian on the podcast the other day.
Yep.
And he, not the other day, sorry, it was a few weeks ago now, but he very kindly said that he doesn't think highly of counterstrain, but that he has seen some very wonderful practitioners apply it and get fantastic results with it.
Yep.
And I've heard practitioners say that they don't think much of biodynamics and in the involuntary, using the involuntary mechanism, yet they think that George is a fantastic practitioner and has gotten fantastic results with what he's done. So there's no reason why that you may not be able to master a technique, or you may not be able to. It may not just gel with your particular character of treatment, which is fine, but it doesn't mean that it doesn't work and that other people can't make it work.
It's not for everybody.
That's not for everybody, but yet, I guess if somebody who would use counterstrain would sit down with somebody who uses another technique, would sit down with somebody who uses another technique, we could probably all sit around the table and discuss rationale and probably have very similar understanding of what the rationale behind things are.
So this is where I can comment a little bit on this, because I've trained with George Stillian as well. And I trained with Ray Myers, who was biodynamic practitioner, Cameron Keeley. So biodynamics, if somebody says that it doesn't work for them, fine, that's understandable. Some people, HVLA doesn't work for them, and HVLA is a fantastic technique. And counterstrain, for some people, if it doesn't work, it's fantastic technique for some other people. The factor where I would say that what they should do, maybe as osteopaths, because if you look at the older osteopaths, so Fred Mitchell Senior, he wasn't doing Chapman's point, right? And Chapman wasn't doing MAT, right? And Jones wasn't doing what you call Chapman's point, I would say. He was doing his counterstrain, right?
Yeah.
Yeah, there is a difference in different practitioners, but in their own right, using the osteopathic philosophy, all of them were great practitioners. And every single technique, they made it work for them, right? So, like, for example, if I go, can I do the same thing in biodynamics? No, because I specialized in fascial counterstrain, right? and like somebody else what they can do. But having said that, am I going to say biodynamics, don't worry about it? No, that would be a wrong thing to say. If I
Yeah.
say, don't worry about HVLA, it doesn't work at all. No.
Yeah. Look, you've also got to look at the body of people that are, I guess, doing these things.
Yeah.
For me, if there's many osteopaths that have looked into something and have found that it matches and falls in line with the rationale of osteopathy,
Yep.
you actually have to at least pay attention to it.
Yep.
And I guess there's work to do, I think, from the fascial counterstrain people to make this a little bit more, to make it more, I guess, widespread within the osteopathic community, and that's fine. That'll happen with time and I guess getting it out there organically. And who knows, in 30, 40, 50 years' time, we might look back on this and
And we
see
say,
that it's another milestone in, we call, much like we like to say, MET is an osteopathic technique and all that,
Yep.
we could look back in 50 years and say, fascial counterstrain is something that we helped kind of develop and champion and pioneer.
I will just say that it is an osteopathic technique. I mean, if you look at it, Dr. Jones, counterstrain, father of
Yeah.
the counterstrain, his greatest gift was tender point, which makes it the treatment more specific for a lot of the people who, like me, who just like to poke the points.
Yeah.
So it is an osteopathic technique, osteopathic inheritance.
Yeah.
And we have more right in terms of
Yeah.
like, as an osteopathic community of this part, than I would say maybe chiropractors or maybe massage therapists or anybody else. But yeah, osteopathic definitely. We have.
So what's been your biggest challenge at the moment, getting this out there to the I guess the profession? And I'm not a chiropractor or a physio. I'm an osteopath, so I'm interested in osteopaths. What's been the challenge for you in getting this technique kind of out there to the osteopathic community and having it embraced?
I suppose the part of the blame maybe goes on me as well in terms of because I haven't had a lot of time to advertise it as well. I mean, the only thing I would say my biggest challenge is to find time because I'm running a full practice and now I have actually got the students who are working with me like as in FCS students, they are osteopaths and they are helping. So the technique is spreading. It is not spreading at the level it would maybe in a few years' time. The reason is because we haven't been very vocal about it. Like I'm teaching courses in Australia at the moment with the permission from Brian. And Brian actually does Zoom in and he comes in and Timothy Hodges comes in and they teach these courses. But as far as propagating the technique or the FCS to the osteopathic community, maybe I need to have presentation more to the osteopathic community. What I've done so far, I've been focusing more on the students because I see, from my point of view, when I was a student, Ray Myers went out of his way because he was teaching me the day before he died. We actually were practicing together.
Yeah.
So
Amazing.
for me, this is something I give back to the osteopathic community because it's like I want to share what I've learned. I'm excited about it. I mean, I'm passionate about it. And I was like, John was actually, he was helping in the beginning as well. So he propagated quite a bit as well. So to shout to John. And he was like, and then because he's busy, as you know, and he was
So John, who are you talking?
John Marshall. So,
John Marshall, right? John Marshall, yes.
John
Okay.
Marshall. So he
Yes.
did help quite a lot in the beginning to set up the entire thing. So that was a very big help, and shout out to him. That I had no idea how to
John
actually
is a helpful guy. John's helped
Yeah.
a lot of people. He's encouraged a lot of people, including myself, to bring what they have and teach. Yeah. So I want to ask you though. I mean, I think one of the good things is that you are bringing it to the students, and it is going to be from the ground up. It has to be for it to be properly done. It's got to get results.
Yep.
It needs to be pressure tested in the community,
Yes.
but it also will become pressure tested within osteopathy, because osteopaths need to look at it and they need to pressure test it, and
Yep.
they're gonna come at you, say it, and they're gonna say things, and you're gonna have to have answers for that, and you're gonna have to have a debate, and you're gonna have to. I mean, this is all part of the process.
Yep.
And I wish you luck. Like, I think it's a good thing, and I think it's a good thing that people will. I mean, we obviously want it done respectfully, but I think it's a good thing that people will ask you questions and maybe poke you a little bit, and try to get answers about it and try to unravel it, and that's not a bad thing. I think that's a good thing.
That's a very good thing because they will actually make me learn as well. So
Yeah.
as far as I'm concerned, I always have utmost respect for my osteopathic colleagues and elders. Like George, utmost respect for him. The guy, he actually made the first time, I think it would have been about 2012 or 2013 when George was teaching, and I went there as a student, and he actually spent good half an hour just refining my hands. And he goes, this is what you are feeling, this is what you should be feeling, this is where it should be, this is where you put the hands. And I still remember that as something that if the other osteopathic students who are actually in the courses now, if we can give something back from what we got, because we got a lot of passion and help and a lot of inspiration. We should be able to give the same thing back to our students.
Yeah, definitely.
But I will be happy to get engaged with a lot of the osteopaths. I mean, you're coming to Melbourne, and as I'm going to put your course link in the
Thank you.
In the group that we do, and we'll get together, and I'll show you what FCS is, like hands-on. It's much easier to explain what we're doing at the time, and you will see. And then most of the and maybe we can record it or whatever, and we can see.
Yeah, we'll talk about that. Definitely, we'll talk about that.
Yeah.
So I want to ask you. I mean, I want to move off FCS for a minute because I think we've talked a lot about it, and I think if people want to find out more about it, it's best that they speak to you, and I'll link to in the show notes to some of the things that you're doing as well. And so if anyone's interested more in fascial counterstrain, get in contact with Syed and the academy that he's got going on down there in Melbourne, and you can go and do the courses with him, or you can at least ask questions and find out what's going on down there, so to see if you're interested.
Yeah, we have started the instructor program as well because one
you
thing
need more instructors.
What we are lacking in terms of FCS because Brian, the first course debut was in 2006, and since then he was in America. So in Australia, we have started to develop that teachers, TAs, and instructors because we are not as lucky as Americans. So they got a lot of courses happening. We don't have
courses,
that.
and they got a lot more people there in that country than we do. Yeah. I touched on earlier on the before I made the introduction. I said that there was a new wage increase within the award wage for graduate allied health practitioners. I think it'll be at $93,000 per year. Syed, where do you stand in terms of what do you do in terms of business? Are you somebody who employs others? Are you somebody who people contract to you? Where do you stand on that?
So my entire thing was when I started the clinic to actually have the contractors who will come and they will be doing the fascial counterstrain because I wanted to make that as a thing that we are treating this particular way in our osteopathy. So it's a complete osteopathy. We train with FCS and we treat the same way.
Okay. So you don't have any employees at the moment with you?
Not at the moment, no, because that logistics and all that, because for me, it's a nightmare. You can imagine trying to run academy and the courses and then the business and then...
Yeah, definitely.
Yeah, that was...
And I guess this has pretty much then made it a lot... Has this, I guess, made it a lot less desirable for you to take on employees?
Yeah, because if somebody is like, if I'm going to train someone for, let's say, 2, 3 years, 4 years, or whatnot, right?
Yeah.
So, it like as a practitioner and a trainer, that it takes good 2, 3 years for them to start giving results the right way, right? So when that happens, they have to retain the patients, and for a clinic to run profitably, you have to have as you mentioned as well, that you have to have 200,000 coming into the clinic yearly.
Well, if you're going to pay somebody,
Pay somebody,
just
yeah,
just under $100,000,
Yeah.
you need to be making at least $200,000 in revenue.
So
You know.
I would suggest Jade would be the best person to talk about that.
No,
Because, yeah,
the only reason I ask you is that this just happened, and you're on the show, and I just didn't know what you were. I figured if you
yeah,
had
no,
employees,
yeah,
you would know a bit about it, but that's okay.
yeah,
Um,
no, I
yeah,
went with the contract model. The reason was because in the beginning, I just went into my own clinic because I wanted to start independent. So,
yeah,
and that's
right.
just build it from there.
And I guess looking at the profession at the moment, I am going to ask you about kind of where things are and where things are going. But before I do that, I want to talk to you a little bit about education, because you do get to see some students.
Yes.
So I want to ask you a little bit about that. And before I ask you about that, what is osteopathy to you, Syed? Like, I ask this to a lot of the practitioners. If you were to define what an osteopath does and who an osteopath is and what osteopathy is, succinctly if you can, how would you define it?
Well, I can define it the best way I can define is from Little John, because I love the guy. He's put it in a very nice manner. He said the osteopathic is a system of diagnosis through which has a particular diagnosis. And now he went into a little bit more detail, saying that it can be any tissue, any structure, anything in the body, which we can go wrong, causing a pathology or whatnot, and causing a long-term ailment or dis-ease in the body, which at the end we are going to use our osteopathic philosophy and treatment, which is specific to osteopathy, to treat it. Now, the question is, what is osteopathy for me? Right? So that was the answer that he gave. My osteopathic philosophy is that, and I use the Arabic word for it, if I'm allowed to.
Sure.
So it would be the Hakim.
Right. So, but you need to translate it.
Yep. Oh, now. So I was hoping you will do it, but
Well, to me, Hakim is translated to doctor.
okay. So doctor is Latin word for educator, right? So the word doctor means educator or so that's the doctor. Hakim is someone who takes into the lifestyle, who takes into the entire
Or physician, I should say.
physician. Yeah. So the Hakim is somebody who takes the wisdom of the nature, of the principles of life, and then put it into how does that affect this person, and how can I make him a better person out of his discomfort. So how can I make it into health? And that's what still meant when he said everybody can find disease, find health.
Yeah. So, do you think though that there are other modality or other professions that stake claim to that? I mean,
They
what
do.
you just said, that's a very broad kind of understanding of what a physician is.
Yep.
And when I say broad, I mean it in a good way. Do you think that other professions though would say yes, we also believe that, and we can be that too?
Yes. So
So then, if that's the case, how is that osteopathy?
difference. Yeah. So the osteopathy for me, we are based on anatomy, physiology, and chemistry.
Okay.
So we should be concentrating on that part of it. Now, that is not a complete picture, and we know that because we can't say that it is cure all system, which Dr. Sil did say that it is when you address the principles, you cure all. So
do you think you could be I guess, a cardiothoracic surgeon and apply osteopathic principles?
yes, because the principles are universal.
Right.
So the principles are never owned by anyone. They are principles. So the anything to be a principle base, that principle has to be correct. If it is not correct, it's not a principle. So the osteopathic principle, they will stay true to the time because they are based on the reality and based on the life itself.
Right. So if I'm an osteopath practicing in 2025,
Yeah.
using osteopathic principles,
Yeah.
would I be in alignment with an osteopath that practiced in, 1890?
If you are using the principle, yes, but a lot of the osteopaths are not, and
Right.
that's where
And so would that be a good definition for osteopathy, is the principles?
it's the principle. You have to stick to the principles because
Right.
osteopathic principle they form the basics, very basics of what we do. I mean, there was a time in osteopathic discussion forum during my young age. I used to debate a lot on those ODF forums with a lot of the other guys where somebody actually mentioned, they said, what Still did is not valid anymore. And I said, what he did back then was as valid as it is today. And if you look at the osteopathic principles, we are following the exact same thing. And if we are not, then you're a practitioner and you might be a great practitioner, but you're not an osteopath.
Okay.
And osteopathic title given by APRA, with all due respect, yes, we do have the title because there is a certain definition by the APRA that is there. And I agree because we have to follow those rules and they have to be a body that is
A regulator.
regulated. We have to be regulated. But does that mean that you're following the traditional osteopathic principles? Not necessarily, right? So
Yeah.
you could do something that is not osteopathic and within the profession scope, it is still considered osteopathically because you're still an osteopath.
Right. And you discussed Ray Myers and his take on a lot of these things about the profession losing some of its osteopathic,
Yeah.
I guess,
Spirit.
spirit, if you want to call it that. Is that, can you comment on that because you were close to him? How would he have seen, I guess, today's education landscape and what's going on in terms of university education and how they are implementing osteopathic principles and osteopathic philosophy and how well it's taught? What do you think Ray would have, what do you think his commentary would be on that?
So, believe it or not, he predicted that. What is happening now? He predicted that about 2015.
Well, what is happening now? Tell us what you think is happening now.
So, if we go to, so we don't have to go far. We can look in UK. BSO is, I think, closing down. The reason being because the enrollment is falling quite short as well. Now, if we are going to do the osteopath, the reason why most of the people were becoming osteopaths, and that's what Ray at the time said, he goes, a lot of the people become osteopaths because they have been inspired, treated at one moment of their life to become an osteopath, or at another moment. They were influenced by someone to do osteopathy. He goes, however, the number of people who are becoming osteopaths because they couldn't get into the physiotherapy is increasing. So the people who are going from they wanted to become physiotherapists because the ATA score wasn't high enough, and they went into osteopathy. So then obviously the school education has changed to accommodate that too, because obviously there are some restrictions placed on the university because university has to make the graduates safer for the public out there. So they have to write the curriculum in certain manner. Now, obviously, funding has been cut from the universities. So there's a whole lot of stuff. Ray Myers used to say osteopathy is the cash cow of RMIT.
Right.
That was his words. So the reason why he said that, because when I asked him, I said, "What do you mean?" And he goes, "Because as long as it is providing students and the fees to the university, it is valid. And the osteopathic profession will keep on making concession for the university until it is not osteopathic anymore, and it is just another course with the name osteopathy on it."
So you can tell me what Ray thought, if he did think anything about this next question, but even getting your thoughts, who do you think is responsible for safeguarding the osteopathy in osteopathy? Like who's responsible for making sure that we maintain the essence of osteopathy within the education tertiary programs that we currently teach?
So we don't have to, well, we can actually look far behind, all the way up to Dr. Steele, right? So Dr. Steele said the major threat to osteopathic profession is the osteopath in itself. Now, if I am to dissect, or if I'm to explain that statement a little bit more in a way, if we flip that statement, so the profession of pathy will be or should be guarded by the osteopaths, individual heroes, so to say, who will actually stand up and say, "No, we are going to do this, because the profession is not doing what it's supposed to do." And you see that is happening every now and then. I gave your example, which a few years back. So you actually stood up and you said the things which nobody else was saying at the time, because everybody was kind of like hush hush.
Well,
right?
it's like business as usual,
Yeah.
as long as we have graduates who are coming out and we can package them, give them a service that they can give to the public. We can package it nicely, teach them how to do it, and just give it to the public. The people will pay us, and then we can run a clinic, and everything's hunky-dory, And my thought process on that was that, especially, see, the problem with having 2 university courses, for example, coming out of Melbourne, has been such a great blessing for osteopathy in Melbourne. But at the same time, it's been a bit of a curse, because what's happened is when you have so many graduates that are coming out and there's lots of competition, you normally what you should do is you should allow the competition to weed the bad ones out. But that's not what's happening. What's happening is that very smart clinic owners, who are very smart people, are packaging a service together and teaching them how to offer that service. And so when you go to a clinic, you often see this. They've got a nice kind of package, and they'll list what the patient's going to get. You're going to get a deep, thorough history. You're going to get half an hour of deep tissue, soft tissue work. You're going to get treatment. You're going to get a diagnosis. You're going to have a treatment plan. You're going to have this. You're going to get that. You're going to get a free foam roller. You're going to have exercise plans and all of this it's like a package that's included, right? And some smart people have figured out that if I could just get some graduates who have some anatomical knowledge and teach them how to do this, they don't actually have to know osteopathy. They'll just have to teach them how to do this, and I can mentor them, and I can have them mentored really well and teach them how to rebook and all this kind of stuff. Then I can run a business. And for a large part of that, it's true, it's correct, they will run a business, but it won't be osteopathy. And what will happen is that a lot of these people will get burnt out. They won't be happy doing what they're doing. They're not doing what they signed up to do. They end up leaving the profession or looking for other ways of using their degree in aged care, in NDIS, in da-da-da. And that's fine, there's nothing wrong with that. But we lose then the essence of that physician that you discussed earlier. And so, that was what I was, I guess, speaking up about. I said, hey, hold on a sec, something's not right here. We're just business as usual. For me, at the time, the association was business as usual. I asked the question, I said, when you guys go to the universities, Do you sit and do you tell them that, you know, we're seeing a trend and that trend is not great? Or do you just give them a pat on the back and say, great job,
Great job.
keep doing what you're doing, well done, and like, are you having this communication? We don't know. I mean, you're representing us. Are you telling them this? Are you not telling them this? What's going on? So that was the essence of what I was trying to say, a couple of years ago, and I'm still trying to say now. And that's how I'd explain that. But I mean, what do you have to say about that? What can you comment on that?
I don't think much has changed. What you said is on the dot, because that's what's happening now as well. What we are doing is we are running the clinics, so clinic is getting richer and retaining. This is how we know. I mean, from my ear level, how many of them are still practicing osteopathy? Not many. And why is that? So we have the uptake of university in the osteopathic course is gone way beyond anything. It's gone like from 20 to 200 per year. So there are a lot of students, but at the end of the day, how many we are retaining? So if we are retaining what we were retaining a few years back when we were just having 20 students, osteopathic profession is not really progressing. We have regressed. And that was the biggest thing. Ray said that there will be a time soon enough that we will not be able to call ourselves osteopaths anymore. Because if you do osteopathy, you will be marginalized.
Right.
And I mean, you
mean if you practice osteopathy or if you actually become an osteopath?
So if you become an osteopath.
Right. Okay.
Like if you do osteopathy as the osteopathy should be, you will be marginalized. People will be putting you on the side.
Okay.
So, I mean, how many times you practice in Sydney? And Sydney, I would say Sydney is great in one aspect, that the osteopaths over there, because there are very few of them, they are actually practicing osteopathy. I mean, Anne Cooper, I remember during my graduate years, I used to read a lot of her stuff because she was straightforward to the point, and she will just tell as is. And Ray actually used to laugh at when I used to discuss her post with him. And he goes, yep, he goes, and he's actually, she's on the point when she's saying stuff. So he goes, pay attention to her, what she's saying, because it's actually more osteopathically aligned. Yes. Because she won't do biodynamics, but what she's doing is osteopathy. Yes. And I understood that concept back then, and it's like, yep, I understood that because she's having the philosophy back up the entire thing. She's still doing the same thing. I'm not sure if she's on Facebook anymore, but she used to have that very, very strong presence and with the osteopathic students. And I think now what the students are missing is that strong presence maybe. And through your work, I think you have just reignited that, which is getting in the people, letting the students know that what they need to do, what they should do. There's a choice. Choose what you want to do. It's like you don't have to go this. You have to follow the philosophy. So you can help the patients out there. You can help the community and the profession itself. Profession will grow. And
you'll earn money. You'll earn really good money, and you won't worry about having to, like if you're a clinic, this is I guess this is a message to a lot of the clinic owners that own and operate medium to large clinics. And I'm talking about osteopathy clinics. I'm not talking about physiotherapy or, I guess the message is that you need to speak up about the quality of osteopathy that's coming into your clinics, because it's directly affecting your business model now. Before it wasn't. Now, as minimum wages have started to go up, you need competent practitioners to get results, not after 1 or 2 years. You need them to get results within 2 months. Like you can't have people graduating, coming into your clinic and spending 18 months mentoring them to start to see a turnover in their revenue. If you're going to pay them $93,000 as a base wage, you need to be able to get at least $200,000 in revenue. Now that means if you just do some quick mathematics, over a 47 work,
Weeks,
a week work year, if you can get them seeing 50 patients a week, that means you're going to have to charge $120 or $130 a consult.
Yep.
Like someone in the public is going to pay $130 a consult to see a new graduate that doesn't get results. Like that doesn't make sense to me.
Doesn't make sense.
So if you want to be able to make that model work, please start speaking to the people who have communication channels in the universities and ask why people aren't graduating with as much competence as you would need them to have.
Yeah.
Okay? And so just ask the question. I'm not saying you need to criticize. I'm not saying that you need to be disrespectful in any way, but that's the solution. Like if you want a proper solution, and as osteopaths, we look for the holistic solution. It's not just about KPIs and measuring this and culture, and we need to have people that can produce results, right? And if you want a holistic solution to your business problem, you need to get it at the root cause. And the root cause is that you're not getting graduates who at the competency level that you require them to be at. Now, that might mean that you invest in courses like yours, Syed's, like mine, like John's. It might be that you invest there. But, I mean, before you do that, go to the universities first. The kids are paying, $100,000 for their university education. The least they could have is that they would graduate knowing osteopathy. And so that would be my advice to busy practice owners in Melbourne is, speak to the universities and speak to your association and make your feelings heard that we need some movement on this, Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy and back to the show.
I'll just add to what you just said there. Unfortunately, the last trip I had when I went to the RMIT, I met with one of the students who said that he went to see this osteopath who told him that he has to be an apprentice for 20 years to get reasonable skill to treat a patient.
Okay, that's a bit unreasonable.
And and he asked me, he goes, what's your advice on that? I said, look, the kid was only 22, 21 years. I said, look, look, maybe I'm coming the wrong way from here, but this is what I look at it. 20 years, you'll be 40 something, right? 44 years. If you start making money at the age 44, you're going to retire very soon.
No. Look, osteopathy is not complicated. It's simple. It's not easy, but it's simple in nature. Yeah. It doesn't mean that it's easy. So, you don't need to complicate it too much. You just need, you need people that are giving you the inspiration to want to be a better practitioner. And that comes from osteopathy. That comes from the principles, from the philosophy. You need people like Ray, God rest his soul, that gave students that inspiration. You need people like you mentioned, like Ann Cooper, who gave us inspiration. Yep. She taught me. She was one of my teachers. Yep. You need those kinds of people. We've thrown the baby out with the bathwater. We've gone to these tertiary institutions. We've told all the proper clinicians that have been there, that have done the hard yards. Look, you don't have the technical skills to be a teacher. Move out of the way. And they've brought in, honestly, people that have barely been practicing for 10 years, and they've taken over the tertiary institution. And there's a reason why students aren't getting the kind of quality that they think they should be getting. I spoke to John Pitcher on the podcast in one of the earlier episodes.
From Victoria University, I remember.
And John Pitcher would be like, I would do it for free. He said, I would happily go back and teach at the university for free, just so I can help out the profession. And John's been practicing for over 40 years. As a great direct practitioner.
I met him during my students' days. So, and believe it or not, I went to the toilet and he was there. And that's where we started talking. We were talking in the toilet for 15 minutes, which is gross. But we should have moved out a bit.
Say the bathroom.
Bathroom.
We're just washing hands.
Washing hands, yeah.
We're washing hands in the bathroom. That's less gross.
But very interesting guy. Like in terms of like he explained quite a few things. He goes, do this. And now, like, you know, as you said, I mean, there are a lot of people. For me, because I came back from teaching background as well, so I actually did a teaching degree back in the days as well. So I taught for a while. So I can tell you that if they are looking for teachers, the teachers who have the skills and who have the osteopathic philosophy, they're looking for, I mean, the university is not going to pay them the wages that they will deserve.
Yeah, no, it's but you get to a point in your career where you want to give back. It's a natural thing.
That's what it is. And
it's a very natural thing that you get to 30 plus, 20 plus, 30 plus, 40 years plus in practice.
And you want to give back,
And you want to give back, and you don't care that you're only getting paid $50 an hour or 60. You're not. It's not your problem.
And they are not hiring those people.
No.
This is.
Yeah, and one of the arguments is that, you know, it's really hard. Teaching has become more than just being able to do a technique. You need to know the administrative side, the technical. You can always help those people with that stuff. You could teach an osteopath to teach. You can't teach a teacher to be an osteopath.
Be an osteopath, exactly. That doesn't work.
And so, it's like I just and even still, I feel pretty kind of. Like this will take time, because even if things change tomorrow, we're not going to see it in the profession for another 5 years. It won't make its way through, you know. Even if things just get a big overhaul tomorrow and all of a sudden, you know, we have, you know, little John reincarnate teaching us. You know, you're not going to see the effects of that for years to come.
Always, when you're working for a profession, when you're working for a goal, you're looking for something that will happen in 10 to 20 years' time. Yeah,
so I think that's where also, I mean, clinic owners tend to look at the short term, you know, how can I, you know, what changes can I make to really help my team meet this new challenge? And the new challenge now is that there needs to be an increase in the productivity because their wages have gone up. Well, instead of just looking at the short term, I think it's a good idea for people to contact the universities, contact the association, and start thinking more about the long-term sustainability of this profession and say, hey, we need to just give our students a little bit more than what we've been giving them. And how can we make that? How can we help you? How can we help you make that happen? And so I hope that there's a few more advances on the I think the internship model that they may be working on at RMIT. I hope that works out very well. We might hopefully have some news on that, and hopefully more internship models to follow at other universities. I think that's a very good way to go, to give some students exposure to inspiration by getting them out there to different clinics and different practitioners, and maybe outsourcing that out of the university's hands and into the hands of private practice where it needs to be done.
I think they do that in Southern Cross University. SCU, so the students actually do go out in their final year and they can work at a clinic. They can observe the practitioner over there and have much more, I think 20 hours or so. So they actually had that.
Syed, what is it that you, I know we've discussed, maybe let's talk about some of the different topics. We've moved away from education and I guess what's going on there, but what do you see as some of the challenges that we're facing in the next 5 to 10 years as a profession?
I think osteopathic will have the identity crisis within 5 to 10 years. Reason being because the way the profession is heading, we are already disconnected from our past. And if you don't know your past, you don't know your future, or you don't have a future. At present, what is happening is we are more, suppose, forced into kind of allied health in terms of where, if I was to ask anyone what is the difference between a physio or osteo or a chiro, most of the students won't be able to answer that. Unfortunately, because we don't know the difference. So more often than not, I mean, when we say what is the difference between the three professions, I mean, a lot of the people answer with that osteopaths are in between chiro and physio. And if I ask them, because that's my question to my patients, because I perceive them as, okay, what do you think is the difference between an osteopath and a physio? And they say, well, you don't do osteopathy because the other osteopath I saw, they didn't talk to me like that. They didn't explain to me like that. And I said, well, this is actually, and I have books of, the older books of osteopathy, and I said, this is what I'm talking about. It is from this book. It says right here. That's what it is.
Well, I'm going to play devil's advocate. Why do you think that's important to know the difference between, or why do you think it's important to have a difference between the three?
The important to have a difference because as a profession, we are osteopaths at heart. The philosophy bit that we do talk about, I mean, chiropractors, they have their own philosophy. Physios, obviously, they are favored by the physicians and the GPs. We are the, as to say, we are the devil advocate in the terms that we are actually thrown out of the bunch. The GPs, not long ago, they never used to like us. Now they start liking us because we start giving them something back from the profession. So a lot of them, they started to recognize what osteopaths are. However, if we start following the physios, it won't be long because the physiotherapists, they are not touching people anymore, right? And from the osteopath...
Why is that important? I mean, why is that important? Well, it's important to us. I know that.
Yes. Yeah.
But why is it important to the public? I mean, at the end of the day, like, why do you think it's important to have a distinction between the three professions? I mean, there's more professions than that. You've got myotherapy and Chinese medicine and all this kind of allied health. But let's take those three professions that would seemingly be the closest together. Because why do you think it's important to have a distinction? I mean, for the public, because for us, I know that we care about it. We should care about it. But I mean, why should the public care?
As a profession to survive, as a profession to have a lobby, as a profession who will be revered and respected, you need to have that distinction. If I was to
But what does that matter for the public? I know, I'm sorry, I'm pressing you on this, but why is that a problem for the public?
If the public doesn't know the difference, for them, whether you're an osteopath or chiropractor, doesn't matter. But
it doesn't matter as long as they get a result. Like if they get a result,
But if they are also, then you talk to them and you say, this is what we are doing. And then something, let's say, our association out of somewhere, out of the good of their heart, they decide to put a big poster for us and they want to advocate some rights for us. Then the people can actually say, okay, these people are osteopaths. We know about them. We are not at the fringe that nobody knows about them. Because let's be honest, I mean, chiropractors, they have more rights than us because of their lobby. Occupational therapists have more rights. Unfortunately, if I was to go and try to enroll in Melbourne University, my degree is not recognized.
Right.
I'm not recognized as an allied health. A nurse is. She can become an exercise sports scientist. I can't go and enroll in that course from Melbourne Uni because my course is not recognized. We did that experiment with one of my associates, Magic Zasada, and he actually went and he talked to them. And at the end, the response he got was that the university actually doesn't recognize this
Right.
You don't have the requirements.
Okay.
So as a profession, I mean, it's a similar in terms of Chinese medicine as well. So Chinese medicine profession, they are not allied health. They're under APRA, but they're not allied health. They're heavily regulated. There are a lot of the herbs they can't prescribe, a lot of the things they can't do because they're regulated. However, what are the benefits for them being regulated?
How much?
For us, we are regulated. I mean, for the public, it's actually a good thing for the public because an APRA is governing body, so it's actually a very good thing to have. But why we are not treated the same as physios and chiros? We have better education, we have better diagnostic systems, yet we are pushed away.
But again, why is that? I mean, why is that important for the consumer? Why is it important that the consumer, that there is a difference between the three professions? Why not just amalgamate them into the one profession? Why not have everybody just be the same? And why, what's the benefit that the consumer, for there to be a distinct osteopath versus a distinct chiropractor versus a distinct physiotherapist?
Because the chiropractors is, again, it's based on a different model to our model of practice. Physiotherapist, again, different model of practice based compared to our model of practice. So can individual chiropractors and individual physiotherapists can treat like osteopath and have philosophy like osteopath? Yes. Can osteopaths have individuals who will practice like physios or who will practice like osteopath? Yes. But as a profession, do we want to be tied in with the chiropractors?
Well, as a profession, no. But again, we go back to that, like the consumer.
Consumers. The consumers
what does
need
the
to have
consumer
that.
care?
Well, again, if we are distinct in our profession and the outcomes are there, the consumers will say, I want to go to an osteopath. Which will give us, again, it's a choice, yeah. So you want to give them that choice to make that informed decision in terms of that this is an osteopath and I'm going there because I know he's going to do this, X, Y, Z. And I know that I will get these outcomes. Yeah. I know that I will not be locked into a $5,000 deal.
Yeah. Ultimately, I think it expands the scope of everybody if if professions are distinct, because if I'm distinctly an osteopath, I have a certain scope and I have a certain skill set and some of that may overlap with another profession, but a bit of that won't. And the consumer will miss out on that if I'm now identical to another profession. Yeah, and so we don't want the consumer to miss out on that, because that could be the difference between their improvement. There might be some osteopath down somewhere doing some kind of technique that nobody else is doing, that they've thought about, and it might be the one technique that just helps a patient when nobody's been able to help them. And it could be argued for the same thing about a physiotherapist. There might be something that they've learned, and I guess if we make everyone look the same, we're really not doing the public a service, because we're reducing the amount of people that we could help.
To put it in a funny manner, I would say that, if you look at the gyro and you look at the doner kebab, so one is Turkish, one is Greek. Yeah. And if we call them together, they look the same.
Be careful. Be careful. Say
and that's what I was.
You're going to politics here.
So, just in that terminology, I would say that's kind of like we can say that it's similar but not similar.
Yeah. Yeah.
But profession needs to have a distinct and differentiation between each other, because that's how we thrive. Physiotherapists, to their credit, they will thrive on their principles.
One thing I didn't ask you about the fascial counterstrain, and I want to, I guess, finish up on this, is that what's the emphasis on research and I guess validating what you guys are doing through scientific research? Is it basically a PROMS model that you're looking at, the patient reported outcomes, or are you looking at actually running randomized controlled trials and going that way? What's happening there, and is it something that is there a lot of emphasis? Is there emphasis on it? Is there something that the fascial counterstrain people, whoever's in charge of making this technique worldwide, is it something they're looking at?
So, what was the first steps that as FCS organization we took was to actually have the rationale. So now we have a rationale that what we do or what we think we do, and there is a rationale which is based on the current science.
That's a rationale for the technique.
Rationale for the technique, and this is what we think happens in the body, and this is what we are doing. I will actually send that link to you, which the viewers can view from there. And that talks about all those cytokines, how we release them and whatnot, and that's how the technique actually gets rid of that. So that was the first step. Now that took Brian good few years to do that. He's publishing another paper very soon enough that will be coming out as well. Then what we are doing is at the moment patient outcomes, because it's the reproducibility of the results. That's one thing which is very common across the FCS practitioners. So we actually, when we find something, it is reproducible.
Yep.
However, when it comes to the randomized controlled trial, Brian and Tim did do a study, and that's a vascular study. I will actually post that as well. They did a vascular study where the scan in relation to the lymphatic points and whatnot, and it was showing and then they did the sonography, and after the treatment they actually looked at the size of the veins that reduced drastically to the normal size. So and the pain was not there for the patient, which was reported. Randomized controlled trial, I think you need a lot of research. You need universities to employ and do stuff. I mean, I'm open to it. That in terms of if the university wants to do a research, I'll go as a practitioner who can actually perform those trials. But obviously,
so that's a work in progress, obviously.
Works in progress, yeah.
Okay.
And that took quite a bit of amount of money as well, because you need a lot of funding from the university. And
it's funny. It's I mean, fascial counterstrain now is I mean, it's something that's practiced widely enough, I guess, to for you guys to sit there in a room and go, hey, I did this and this worked, and the other person say, I did the same thing and it worked, and you'll be on totally different parts of the world or in different parts of the country. And so someone said something the other day that I found quite interesting. It's like when you're discussing research, it's like a whole bunch of practitioners sitting in a room going, hey, we know that this works in practice, let's find out if it works in theory.
Yeah. Well,
it's like, what do you care if it works in theory? It works in practice. We're getting people right here. Like, let's find out now if it works in theory. It's like,
I mean, osteopathic research. If you look at, if I remember correctly, I think it was 1924. They did a lot of research back then in the days.
Well, they had hospitals back in those days.
Yes. Louisa Burns was the lady who actually performed a lot of those trials where they ended up having, if somebody's jaw was dislocated even centimeters, and it will dilate the amylase, which will affect the digestion process, which will affect. So they did the entire type of these kind of research, and it was amazing. But obviously, it took a lot of time and effort, and on their time fundings as well at the time.
Yeah.
I'm not sure if Osteopathic Association would be willing to do any of that. If the university would be able to fund those, if there are any people who want to do PhD.
You could put it to them. I know they have research grants. They do offer research grants. How much money you would need, I don't know, but it's definitely something you would put to them if that's something you want to do. But
we do.
I think that's. You go ahead.
Sorry. We did have a chat with Azhar as well. I think that was last year. We had a chat with him, and he was interested in opening up the research model for it as well. So he said, he would be interested in doing something like that. But again, research normally takes about 15 years to catch up to
Yeah.
what we are doing at that moment,
Yeah.
as has been the history. So my focus is mainly in Australia is to propagate as much as I can
Yes.
before my times is up.
Yeah,
and then-
I think that's a good strategy. I think you need to get it out there in the clinics, have
Yeah.
people doing it, getting results, and then
Yeah.
that will build a groundswell where then somebody will be
has to be researched.
interested in research, and they will do it. So yeah, definitely. All right. Well, Syed, I want to thank you for your time this evening. We've just
Thank you
done
very
just over 2 hours, which is great. And hopefully it's been interesting for people to watch. I'll get you to send me some links, and I'll add those to the show notes, and hopefully people can reach out to you if they have more questions about fascial counterstrain. And I guess if you're in Melbourne and you're a student and you want to reach out to Syed and just get his thoughts on things and find out what's going on with osteopathy in his brain, get in contact with him and go out and observe. For everyone that's watching, thank you for joining me. Syed, stay on the line, but for everyone else, have a good evening, and I'll catch you on the next episode.